Welcome everybody, and thank you for joining today's webinar on behaviour support and restrictive practices. My name is Dr. Melanie Roth. I am a geriatrician and the Chief Clinical Advisor with the Aged Care Quality and Safety Commission. I would first like to acknowledge that wherever we are in Australia today, we are on Aboriginal land, and I pay my respects to the traditional owners of these lands and to their elders. I'm talking to you from Gadigal land. I extend that acknowledgement and respect to all Aboriginal and Torres Strait Islander people who are joining us today. In our webinar last month on restrictive practices, we began a conversation with you to clarify some of the myths that we have seen and heard on this important aspect of practice in aged care. Last time we focused on the non-chemical restrictive practices. It was an important discussion and set some ways to help when thinking about restrictive practices. And if you missed that webinar, I do recommend that you watch it. The link is available on our website. Today's webinar, however, will focus on chemical restraint and behaviour support planning. One of the myths we hear about chemical restraint is that it is not permitted or it's not supported or that the Commission disapproves of its use. We hear about doctors being told they can't prescribe it and a general fear surrounding the use of chemical restraint. We hear that doctors are being asked to change diagnoses or that people are being left distressed. For some individuals, an appropriately prescribed chemical restraint can relieve distress and improve their quality of life and improve the care and options available to them. However, chemical restraint can also cause great harm. So it's really important to understand the use, the benefits and the harms, and that will of course guide the monitoring and review. There needs to be clear rationale for its use, guided by careful and person-centred assessment, so each person as an individual. It needs to be the least restrictive option, obviously, and it needs to be used for the shortest amount of time and in the lowest effective dose. If it's causing more harm than good, it needs to be stopped. And in order to make that judgment, you need to be very clear on what the harms are, they're likely to be, and then what they are in that person. It's because these are powerful and risky drugs, and we know that they're still overused, that there are obligations on providers on how they're used, and we will explore these today further. Behaviour support planning will also be discussed. Again, the impact of behaviour support planning to an older person living with a cognitive impairment can be life-changing. And we've seen numerous examples of this. It can prevent the use of restrictive practices, and it can certainly enhance the quality of life of the person. And so this in turn impacts all of those in your care and also the morale and safety of your staff and other people involved in the person's life. So today we will cover chemical restraint and behaviour support planning. We'll look at some of the myths and common misconceptions that we see, and we'll look at practical supports available. Joining me on the panel today are Lauren de Vries, who, as you know, is a nurse practitioner. She's our senior practitioner for behaviour support in the Aged Care Quality and Safety Commission. We've also got Megan Cox, who's a registered nurse and is the director of the Restrictive Practices Unit in the Commission. And we're very honoured and pleased to have Jenny Summerton with us, who's also a registered nurse, and she is the National Program Manager for Dementia Support Australia. Jenny's going to tell us about some of the practical supports that are available for providers. And we at the Commission really are committed to supporting the sector to understand this topic. We want you to know that we understand the challenges in caring for people living with dementia on the front line. All of us on the panel have been closely engaged with people living with dementia who are distressed, in pain, unhappy, agitated, and aggressive. We know that people who do not want care can cause distress to staff. We must all remember that your challenges are actually because of the challenges to the person living with dementia. First, some very brief housekeeping. Thanks to all of you who submitted many really intelligent questions ahead of the webinar. Many of these show how keen you are to get things right for your residents. You can also submit questions at any time during the webinar via the live Q&A tab, which should be visible on your screen. And we've got a survey at the end, which I'll remind you about later. So I'm just going to start now by asking Lauren to kick us off.
Great. Thank you so much for that. It's really exciting to join you all here today to talk about restrictive practices, and in particular chemical restraint and behaviour support planning. So here at the Behaviour Support and Restrictive Practices Unit, as you've heard, we are all clinicians, so we absolutely understand what it's like to support somebody who's in distress and really try and deal with those challenges that we have. It's really important that we understand from talking to providers that they are aware of those legislative requirements, and we understand that providers have access to the definitions and the quality of care principles. However, what we do want to support providers in doing is to actually understand how to implement those legislative requirements. So we want to try and impart those practical implications of these requirements. This then brings us to these myths and misconceptions which we commonly hear, which means that the requirements are often not met when people are trying to do other things that they don't actually need to do. It also means that a lot of staff time is spent doing things that are not a requirement, and that's why we're here today, to try and clarify these things. And of course, just to highlight that this webinar does complement that first webinar, which looked at the non-chemical restrictive practices. So we do encourage you to go back and view that again. So today we're going to start by looking at chemical restraint. And as you can see, that's one of the types of restrictive practices. But as you can see, chemical restraint is a practice or intervention that is or that involves the use of medication or a chemical substance for the primary purpose of influencing a care recipient's behaviour, but does not include the use of medication prescribed for. So we've got the treatment or to enable treatment for the care recipient of a diagnosed mental disorder or a physical illness or a physical condition, or of course, end-of-life care for the care recipient. Now that definition tells us a lot of information, and so therefore today this is why we want to clarify people's understanding about this definition. Some really common myths that we see here at the Commission is that the consumer's diagnosis is the only factor that needs to be considered. And what we'll explore further is that it's not all about the diagnosis. The diagnosis forms part of a bit of a puzzle that as a provider you need to put together. But the key point is really what is the intention of that medication, not so much what is the consumer's diagnosis. So we often also hear that only PRN medications are to be considered a restrictive practice. And of course, we know that that's not, that is a myth. And it's really about the intention of the medication and why has it been commenced. We also see that providers will have behavioural and psychological symptoms of dementia down as a diagnosed mental disorder. So BPSD is a symptom, it is not a diagnosed mental disorder. So therefore, the use of a medication still needs to be considered a chemical restraint, even with a diagnosis of BPSD. And the other common myth that we see is a diagnosis of anxiety or a diagnosis of agitation, and providers feel that that also potentially might be a diagnosed mental disorder. However, again, both of these are symptoms, and we need to understand those symptoms more before we need to ascertain whether it's a chemical restraint or not. I'm now going to hand back to Melanie, who's going to have a look at the psychotropic register, which is really a key tool that providers can use to gain an understanding of their prescribing.
Thank you very much. I really want to draw your attention to two key parts of the psychotropic self-assessment tool. Many of you will be familiar with this either in its current form or in a form that you've adapted for your own use. As you know, it's not compulsory, but it's designed to really try and help you oversee this class, or this family, if you like, of high-risk medications that are the psychotropics. So if you go to B, where the first red circle is, and it says reason for prescribing, now you will notice that that does not say diagnosis. The diagnosis, of course, may well underpin or provide context for the reason for prescribing, but you could have 10 people with dementia who are on various different psychotropics, and dementia is not the reason. The reason is their agitation, their aggression, their hallucinations, their underlying schizophrenia, calling out or wandering. So the reason why it's being prescribed is the reason why this medication is, a decision has been made that this medication is required for this particular person now at this point in time. So it will really help you, if that reason is quite clear, decide on many other things. It will help you decide, if you know what the reason for prescribing it is, it will help you decide whether it's working. If you don't know why it's been given, how can you decide whether it's working or not? And it will also help you decide whether or not it is chemical restraint. So it really will help you if you can clarify what the reason for prescribing is, and that doesn't have to be the doctor telling you, because often the prescribing will be as a consequence of what you've told the prescriber. I'll come back to that in a tiny bit more details, but column C, which is if PRN, the circumstances for use, that goes to the same thing. So if that's blank, let's just say that a person is prescribed risperidone PRN. How do you know when you're going to use this? And maybe somebody who's using it at night will have a different threshold or a different reason or a different perception of it from somebody who's using it during the day. So it's very much open to interpretation. And when you're giving consent for this medication, or when you're prescribing it, that might not be your intent. Your intent might be only to give a PRN medication if the person is very distressed by a particular thing, or that distress is manifest in a certain way. So only if the person's very agitated. Of course, that's if that agitation can't be settled down by other means. But you wouldn't want it used just in case, or you wouldn't want to use it so that the carers have a nice quiet night. You want to be very clear that you're using it for a reason for the person. So that's the two parts of that I wanted to draw your attention to. Then that will help you with E. Has it been, do you believe it's a restraint? And if the reason is anything to do with behaviour, then of course it is. And it will then also help you go on to, is monitoring occurring for effectiveness and side effects? You can't really monitor for effectiveness if you don't know the reason that it's being given. And likewise, you will need to have an understanding of the potential effects, impact or side effects, and I'm going to come to that in a little while. So I'll just move on now to talking about the risks and benefits. Now this slide is just giving you an idea of the risks and benefits. Now, of course, any decision we make in life, we're balancing the risks and benefits of what we're doing. If something's all risk and no benefit, even if the benefit is thrill, there needs to be a benefit to us to take a decision that has risks associated with it. Now, in prescribing, a prescriber and also the person who's giving consent will need to weigh up the risks and benefits, because you want to be giving a medication that is of overall benefit. If it's actually of overall harm, you don't want to be giving that anymore. You'd want to be looking at another way of assisting the person with whatever their particular current problem is. So this is 1,000 people, each little figure there, and I'm talking about antipsychotics now, which are obviously commonly used as a chemical restraint. Each figure represents 10 people. If you're treating 1,000 people with BPSD with an antipsychotic for 12 weeks, 91 to 200 of these 1,000 people will show a clinically significant improvement, which may be small, but this is talking about clinical significance. 10 people will have an additional death. There will be 10 additional deaths. So that's people who are dying when they wouldn't have died if you hadn't given this medication. 18 of them will have a stroke, and 58 to 94% of people will have an increasingly disturbed gait, which of course leads to falls. So that just goes to show that you need to be very clear that it's not all benefit. And if we go on to the next slide, it just looks in a slightly different way at benzodiazepines, which is another common class of drugs. Of course, drugs used for chemical restraint are nearly always used for their sedating qualities. It's to settle people down or calm them down in whatever way their behaviour is manifesting that distress or agitation. So if benzodiazepines are used for insomnia and anxiety, which is the two common reasons for them being used in elderly, for insomnia, it's likely to increase the person's sleep time by 30 minutes. But after 2 weeks, it will lose its effect. That's because people get tolerant to benzodiazepines. So you can see that the evidence for using it for long-term insomnia is not great. And particularly if that insomnia is manifesting in behaviour. So if the person's wandering around at night and you're using a benzo to help them sleep, you can see that you're not overall doing them a lot of good. Anxiety, does have an anxiolytic effect. It does reduce anxiety, particularly reduces the physical signs of anxiety. So somebody who's restless with palpitations, sweating, rapid heart, all the things that you feel if you're anxious yourself, these drugs do reduce those physical signs. But of course, you also get loss of the effect and dependence. So in most older people, and this has come from therapeutic guidelines, most older people, the advice is that the risk of harm exceeds their benefit. So again, you need to be really, really clear on why you're using these medications. So I want to go, because chemical sedation is usually what chemical restraint is working by, and what the harms are. So the harms of the actual medical side effects are, of course, sedation. I'm going to go into that in a tiny bit more detail, but there's an effect on your balance, which leads to falls. There's an effect on your nutrition, which leads to many other problems, but pressure injury is something that you might relate to. Loss of independent function or reduction of independent function. And then there's the anticholinergic side effects, cardiovascular side effects, premature death, and reduced interaction. So the reduced ability to participate in activities or conversations, and all of the things that people really consider, all of us consider, contribute to our own quality of life. So in relation to the medical side effects of psychotropic drugs, when people are on either a high dose or on more than one medication where they start to compound the side effects, there are tools for estimating what's happening in that person. And I've just listed 3 different tools there where you plug in the person's medications and the doses, and it will come up and telling you what sort of anticholinergic burden there is. And if we go on to the next slide where it shows anticholinergic effects on an elderly person, I don't know why I like this person, but I like this person. But look at the sort of things that you will be seeing in your residents that you may not be aware are very likely to be due to medications that they're taking, and particularly in combination. And there are other medications that aren't actually psychotropic that will also contribute to a anticholinergic burden. So you need to put in all their medications. And I think sometimes you will be horrified in what you think is just a normal list of medications. So the dry eyes, blurred vision, dry mouth, which of course difficulty eating and slurring of the speech. Indigestion and reduced appetite, constipation. How many of your people who are constipated do you think, if you actually looked at it, it's possibly a side effect of the medications they're getting? We know about confusion, dizziness, making their memory loss worse, making their disorientation and drowsiness worse. Respiratory, so the lungs can be affected, particularly you'll find worsening sleep apnea, worsening of the effects of COPD, and increased likelihood of pneumonia. Bladder, where people have difficulty urinating or are more inclined to get urinary tract infections, and of course their mobility, where reduced mobility and falls come into play again. And one of the things that, if you think about it, I think you can probably think of some of your residents who are very sedated. So if you go into a service, if we go into a service and you see lying around people who aren't like that, but numerous people who are all just drowsing all day long, the first thing I would be doing is looking at their medication chart. And even if you really think that the risks in that person are still high and they still do require some sort of chemical restraint, if they're drowsy all day, the dose needs looking at. So the risks of oversedation are falls, pressure areas, poor nutrition, where you lose muscles, you lose your immunity, you become increasingly frail, and you have no energy. Incontinence, obviously you're not awake enough to get yourself to the toilet. A lack of meaningful socialisation and interaction. And there's a depersonalisation. If everyone is in a room drowsy, they will all tend to be treated the same and thought of as not as individuals so easily. Loss of autonomy and dignity, deconditioning, and reduced participation in pleasurable activity. And that flows on to whether or not you're actually compliant with the quality standards. They will certainly affect your quality indicators, not just your antipsychotic or polypharmacy quality indicators. They impact on the level of nursing and the care needs, and quality of life is probably the most important impact for the people actually impacted, the people who you're giving these medications to. So I think that at this stage I'll move right on to Lauren to talk about how you can support the person without or alongside the need to use some sort of restrictive practice.
Thank you so much. Thank you for that. So we're going to start talking about behaviour support planning. And if we think about supporting behaviour, that's just really supporting the person. And we need to understand it needs to be individualised and proportional to the complexity of the distress or the behaviours that individual is having. It's really about prevention. So often it really is just good care, but it's really important to document that, because that then supports your staff and they're very clear on what an individual requires. So there, of course, needs to be knowledge of the individual, their interests, their habits, their life, their occupation and their family. But often it needs to be bigger than that. We often see behaviour support plans that do have that information, but then the information stops being individualised. There needs to be involvement with family or whoever is important for that individual person's life. Maybe talking to previous GPs or their current GP if they know the individual well, and of course any carers. There's those ongoing attempts, what has been tried, the communication that is best to use with an individual, what triggers an individual responds to in a positive way and also in a negative way, and what calms or settles an individual as well. And it all goes back to documentation and communication. We often have discussions with providers and they tell us that, yes, we have tried this and yes, we have tried that, but we look through progress notes and we look through the behaviour support plan and there's no evidence that any of those strategies have been trialled. It's really important to be a little bit creative and think outside the box a little bit. And most importantly, put that individual to the centre of all this planning. What must it be like to be that individual? And there is expert advice out there for support. So your general practitioner, perhaps a psychogeriatrician or a geriatrician, a psychiatrist, a dementia clinical nurse consultant, having discussions if that individual consumer has spent time as an inpatient. And of course, which we'll learn more about after, is Dementia Support Australia, which is 24 hours, which is a great support that we need to use more as a provider. So if we think about understanding behaviour support plans in residential, and we will talk about home care very soon, Improving behaviour support planning was definitely a recommendation from the Royal Commission, and changes were made to clarify and strengthen provider responsibilities in regards to having behaviour support plans in place. And that needs to be in place for any consumer who experiences a changed behaviour, or for any consumer who may need the use of a restrictive practice as part of their care to manage the risks of harm to the consumer and or others. And the use of the behaviour support plan is not just a legislative requirement. Behaviour support planning is best practice, and this can really enhance the care and services of an individual, and that means there'll be enhanced wellbeing and quality of life. Behaviour support planning can reduce the use of inappropriate restrictive practices, such as chemical restraint or physical restraint. And the use of these restrictive practices can overall impact a consumer in a negative way. So that's why it's really important that we document and we're very clear on how these behaviour support plans can support us. The other aspect of behaviour support planning is that a good behaviour support plan can support staff and support providers. The way that a behaviour support plan can do this is by ensuring that staff are very clear on how to interact with an individual, what triggers to look for, how to mitigate risks of a consumer, and what to do when a consumer's distress is escalating. It really does support providers and reduces the risk for the provider, but also most importantly for the consumer and those others that are in the consumer's life. This is why we feel it's really important to focus on behaviour support planning today. I'm now going to hand over to Megan, who's going to now talk about some home care.
Thanks, Lauren. So we also wanted to cover off understanding behaviour support plans in the home services context. And this is quite a common question that we are asked around, and I recognise that this can be a challenging area. So just to carry on what Lauren was saying in regards to best practice, behaviour support plans, while may not be a specific legislative requirement in accordance with the quality of care principles, it is still contemporary and best practice for home service providers to develop and implement a behaviour support plan for a consumer that may require one. It is really important to recognise this also links in with requirements in accordance with the quality of care standards, and this relates to best practice clinical care. So while a behaviour support plan is considered contemporary and best practice, it is important that it forms part of the individual consumer's care and services plan, and it shouldn't replace that plan itself. It is also important that if a restrictive practice is used, that plan sets out all the relevant information about the use of the restrictive practice. And as an organisation for a home care provider, you will have your own organisational systems and processes to determine how best to reflect that information in the consumer's plan. But what is really important is that care and services plan or behaviour support plan working together considers the individual risks to the consumer, their health and well-being, to deliver that safe and effective care. It should also address the consumer's current needs and goals and preferences, and importantly developed in collaboration with the consumer if they're able to, or the other relevant representatives or experts involved in the consumer's care. Another aspect is making sure that plan is readily available for the consumer, but also staff, because the purpose of this plan is to provide clear guidance so staff can effectively support the consumer from a behaviour support element, but also if a restrictive practice is being used as part of their care. So let's talk about what should be included in a behaviour support plan. And this is also a really common question that the Behaviour Support and Restrictive Practices Unit hears from providers. So we are seeing a variety of different behaviour support plans in how providers are approaching these plans. But what we are seeing commonly is that they are generic, or they're insufficient in the information that is in those plans, and not showing that there's comprehensive assessment and ongoing assessment to inform those plans. So what is really important is to demonstrate how the behaviour support plan is being informed by that comprehensive person-centred assessment that's really seeking to understand the unique individual, but also tailoring strategies that are considering the individual's needs, wants, preferences. It is important that the behaviour support plan is actually implemented. So what we do see is sometimes a behaviour support plan has been developed, but there's not evidence that staff are actually implementing the strategies that are outlined in that behaviour support plan, or the strategies that are being utilised and not actually included in the behaviour support plan. So there's not a consolidated documentation from that point of view. It is really important that the behaviour support plan is being updated and reviewed on a regular basis. And when we refer to a regular basis, that's going to depend on the individual consumer and their circumstances. And that is also that someone may need their behaviour support plan reviewed more frequently because there's more specific changes happening to them at that point in time, whether there's an acute clinical need or an escalation in their behaviours, and any other changes such as medications that need to be considered. When those reviews are also undertaken, it needs to be meaningful and that there's relevant consultation with the relevant people as part of that review. Another important element is considering when looking at the behaviour support plan is looking that there's technically two parts to it. You have the behaviour support aspect, then you have the restrictive practices if they're being considered or used as part of the consumer's care. So if a restrictive practice is being used, the reasons for the use of that restrictive practice needs to be clearly outlined in the behaviour support plan. And that also is to clearly outline the articulated risk of harm and making sure that the reasons for the use are quite clear in that behaviour support plan. And that again goes back to the individual consumer's circumstances. I just want to flag on this slide as well the difference in regards to, we've talked about the requirements for residential. So in the context of the quality of care principles, that does set out the specific requirements that providers need of what information or matters need to be set out in a behaviour support plan around behaviour support, but also how a restrictive practice is to be used, monitored and reviewed. And then we've talked about in-home services. So while the quality of care principles currently do not include home services in those behaviour support plan requirements, it is still best practice and contemporary practice for behaviour support plans to be developed and implemented as part of care in a home services context. And that's where that plan should set out all relevant information about the consumer, the relevant assessments, and the information to guide staff about the safe and appropriate use of the restrictive practice. I just want to touch on quickly one of the common things that we are seeing around behaviour support plans, and that's with behaviour support plans being identified as insufficient and not fit for purpose. Sometimes we're seeing the plans being pages and pages long, and the information within the plan is not clear, or they're quite short and generic. So what do we mean when we're talking about generic and superficial strategies? This can also be as a result of cut and paste templates that are being used, or the use of drop-down boxes. So as you can see on this slide, it's showing those generic sort of strategies and interventions for Peter, saying Peter can get agitated, he can disrupt others through calling out, he can wander. There's no specific or individualised information. And sometimes what we're also seeing with these strategies is that they're identical across consumers' behaviour support plans, which doesn't demonstrate an individualised, person-centred and comprehensive assessment to best support the individual consumer, so that staff have a clear picture of their individual needs, who the person is, what their behaviour actually looks like. Offer a cup of tea, provide reassurance, Peter likes music. These again are very generic strategies, and they don't actually help staff understand how to best support the individual consumer. What does agitation look like for Peter? Because the way Peter may display his agitation is going to be different to another consumer and how they may display their agitation. And it also can be because of the trigger or the causes to that agitation at that point in time. When referring to strategies such as likes music, what does that actually look like? Being really specific and making sure that when we're talking about the ineffective behaviour support plans, these are missed opportunities to really identify those quality strategies that are going to optimise the individual's quality of life, and also can minimise the need for a restrictive practice as well. So lastly, let's just have a look at what person-centred looks like. So as you can see, this is just an addition to more specific information to provide those insights to Peter, to understand him as a person, the potential risks, what could cause his behaviour, the more specific information. So this actually describes what his agitation looks like, and that can involve him pacing up and down the hallway. And that can also be a cause because he's looking to go to the toilet, or he might want to go outside into the garden. The interventions and the strategies to support Peter are a lot more person-centred and tailored. It actually says he has a Spotify playlist and what type of music he likes, because when it refers to just music, that actually doesn't tell staff how to support the consumer, and it doesn't paint that picture of who Peter is and what he likes and dislikes in that context as well. So the point of the behaviour support plan is that proactive approach to prevent those behaviour changes from occurring, but also best support the consumer should they experience a changed behaviour. So I'm now going to hand over to Jenny to talk about Dementia Support Australia and behaviour support in more detail.
Thanks, Megan. Hi, I'm Jenny. I'm one of the National Program Managers at Dementia Support Australia. And what I really want to start to just give you a bit of a snapshot of all of the programs that we do have here at Dementia Support Australia to help you, your team, the staff, or the family members that you that are supporting that person living with dementia. So as you can see, we have quite a broad range of different programs. I just really want to highlight that it starts right from trialling respite, which is our staying at home. So people living in their own home can trial some respite, a 2-day, 2-night program, all the way up to people were assessing eligibility for the needs assessment for eligibility into the specialised dementia care program. The other thing I'd like to highlight is that the DBMAS and SBRT is for anybody who is supporting somebody living with dementia. So if you are a home care provider, you can put in a referral to Dementia Support Australia, and we are here to help you to help really understand what's happening for that person, why that behaviour is happening, really breaking it down and seeing what the contributing factors could be, and putting in some really practical non-pharmacological interventions to help support that person living with dementia. Some of our supports may just be on the phone or us coming out in person, but either way, we are involved, and that is what, you know, the Commission are also looking for. If you're looking for some dementia support, is even on our phone support, we will send you some really great practical advice via email, or we will be on site to do a really comprehensive assessment to see what's happening for that person that you're caring for. So some things I want to talk to you today about is about how to really optimise some of the supports that we have here at Dementia Support Australia, and whilst you have a consultant looking at that person living with dementia. So on the next slide, I've just got some points around some things around change that you might see. So navigating change with dementia supports some unique challenges. With diverse nature of dementia, its impact on people's behaviour, new barriers to behaviour support can easily arise daily. To navigate these challenges, a flexible and adaptive mindset become key tools in effectively responding to these changes. Caregivers and support staff can be supported by adjusting strategies, approaches as needs as they are needed to meet the individual needs of the person living with dementia through a personalised, relationship-based approach to care. So, how do we set some reasonable expectations? So it's important to understand that even with the most effective behaviour support practices, they're not infallible or perfect. We mustn't throw the baby out with the bathwater. Dementia is complex, and what works today may need to be adjusted for tomorrow, and that's okay. Instead, it's about having a toolbox of strategies that we can trial and acknowledging that changing nature of dementia can impact the effectiveness of support practices. So really means that in that behaviour support plan, it's really vital to have lots of different options to really work through, because something that you might trial may not work. So let's move to the next option. So as Megan had shown in a really good behaviour support plan, if it's detailed, someone picking up that behaviour support plan can really read it and go, okay, that's how I need to approach that task, that engagement opportunity for that person that we're supporting. We also want to celebrate the small wins by recognising that all those victories that come along the way, even small improvements, can have a huge impact on someone's well-being. We may have, the showering or something like that may be something that you're looking at that, Betty's not really wanting to have a shower and we're really having difficulties getting in the shower. If it goes from 5 days of not having it to 3 days, celebrate that win. You've actually reduced that behaviour and been able to support Betty in a really personalised, relationship-based way. Be sure to set realistic expectations and consider that success in behaviour support may be more around reducing distress rather than eliminating a particular behaviour. The goal is to enhance the quality of life of the individuals living with dementia by minimising discomfort and enhancing well-being. So how do you maximise the support that DSA can provide? It's a really good point to show out how your teams can maximise the support that we can offer you here at Dementia Support Australia. We're here to support 24 hours a day, 7 days a week. You can always call us on our helpline. It's a really great way to start. Your teams can refer to us in many different ways, but as you know, you'll have the information if you do have a dementia support referral in place that we can support through our reports or on our phone as well. So what we must also look at is how that we can utilise those Dementia Support Australia reports and implement them into your behaviour support plan. Generally, it will come through as a contributing factor. What might be causing this behaviour that you are seeing with the person that you're supporting, and therefore after that giving some practical recommendations. Generally they're on the non-pharmacological intervention side. So those can then be incorporated into your behaviour support plans, but it's really important that everyone can see, anyone who is having interactions with that person living with dementia can see and have access to either the reports from Dementia Support Australia or the behaviour support plan, so they can really understand what they need to do when Betty's not having a great day. It's also really important to know the person. So really about engaging as many people into those behaviour support plans as possible. Family members are a really great place to start. On our website, we have a really great tool called a little bit about me, and it's a great way to collect a really comprehensive personal history of somebody that is meaningful, and then you'll be able from that to extrapolate and to build and grow some really great behaviour supports that are relationship-based and person-centred. Role modelling the DSA strategies to your team. This is really important to actually put stock into some of those non-pharmacological interventions and to let your team know that, okay, that approach didn't work today, let's try again tomorrow, or that worked today, let's try it again tomorrow. So really role modelling, what does it look like? When we say, greet the person this way or that way, it's really about showing, is there a person in your team that really has a great way with this particular person living with dementia? Let's look at it as a team environment, and maybe they can, pair people up to see how they are working with that person, and then we can grow and learn that way. Emphasising the importance and effectiveness of non-pharmacological strategies can encourage staff to think creatively about personalised response to changed behaviours that don't involve medications. Finally, I'd like to say, please consider proactive actions that can be taken before DSA is involved. There are early interventions or strategies that we've given you before for this person. Let's go back and have a look at those and see whether or not we can implement them again. Are we doing them right? Bring the team together, have a huddle and have a discussion about what's happening for Jim or for Bob or for Betty, and just really see how you as a team can really build that. Try and implement as much as you can, do a lot of assessments, go back over what we've done before for that person, have a look at the report. Has everyone in your team read the report? And then escalate to Dementia Support Australia. We are here to help. Like I said, we're here to help 24 hours a day, 7 days a week. We have our 1-800 number that is always manned by a dementia support consultant who can give you some in-time, realistic ways to support somebody living with dementia. So here's just some key questions to think of when you are popping in a referral to Dementia Support Australia. It's really about, what is the goal of the referral? Let's be realistic. What can we do to reduce? What is a realistic outcome for the referral? Is the change acute? This is where you need to do some investigations, do some assessments, see what's happened and changed for that person. Have they been part of DSA previously, and is there a report available? Make sure everyone gets a chance to read the report and really get to know the person. We generally pride ourselves on having a really comprehensive personal history that might actually bring some ideas of why that behaviour might be happening for that person living with dementia. Is there documentation on the impact of the strategies? This is really important because, like I said before, don't throw the baby out with the bathwater. It might not have only worked once, but let's see how it worked. And if it didn't work, really document why it didn't work. Maybe we can, from that, investigate it's actually reduced it. So it still is a really valid recommendation and something that we could put into the behaviour support plan. And have these strategies been trialled over time? If anything that you can take away for supporting somebody living with dementia, it's really about the strategies take time. Something will not magically work and reduce that straight away. It'll be something now, something a little bit later in 5-10 minutes, and then a little bit more. And then that may not work tomorrow, but something else will work. So it's really about trialing over time, giving it time, and really getting to know the person living with dementia and making a relationship-based, person-centered behaviour support plan. Thank you. Over to you, Megan. Oh, I think it's Melanie, actually.
Thank you. Yes, I'll take it now. Look, we really very keen to get on to our question and answer sessions. Thanks for everyone who submitted questions. I think some of them may have actually been answered just in the presentation, and we've got some clear themes. We'll just have time for a few questions today, but we will collate all of the questions, hopefully into themes, and answer them, and put the answers on our website as well. I'll just start with this one, Lauren. It's come through quite a lot, actually. How often should chemical restraints be reviewed?
Perfect. Thank you so much for that question. And that is a common question. There's, again, some myths associated with that. The answer is as often as necessary, in a very quick summary, I suppose. So there needs to be that individualised assessment. And there's no sort of golden rule that the Commission or even that's recommended as best practice, because for one individual consumer, it might be that they've just commenced on a chemical restraint, or their behaviours are really quite extreme and the risk is quite extreme. And that may mean that that individual is reviewed every day. And particularly when someone commences a medication and there's monitoring of side effects. For some consumers, it might be a week or it might be 2 weeks. It really does just depend. So think about what's happening for that consumer, how you can reduce the risk and things that you're monitoring and looking for, and how you're going to monitor that in a reasonable time. So I think it's not necessarily about, a certain time. It's about completing that individualized assessment, looking at that individual consumer and working out what is going to be best for that consumer.
Thanks very much indeed. Megan, here's a good question. What do we do with a family member that insists on their loved one being prescribed a medication, for example, risperidone, to stop them calling the family repeatedly?
Thanks, Melanie. And this is a really good question, which I think also highlights the importance of undertaking appropriate consultation, and providers recognizing that this might actually require more than one discussion with the relevant people. And this involves seeking to understand why the family member is requesting the medication. Also, views need to be taken into account for the individual consumer, because there could be potential negatives of a medication. And this highlights the importance of behaviour support as well. So going back to the question of seeking to understand why the family member is requesting the medication, and where the role of behaviour support comes in, has the provider sought to identify and support those behaviour support needs? What does that actually look like? And is there a process to include family consultation in the development or the changes in a behaviour support plan to try and reduce any potential unmet needs? And that's where allowing sufficient time to make sure that you're providing all the relevant information to that family member, and allowing that opportunity to ask questions and raise their concerns, and also considering whether it might be beneficial to involve relevant experts such as the general practitioner or Dementia Support Australia as part of that consultation, to see what is the best and most appropriate strategy and approach for that individual consumer.
Jenny, once we try DSA recommendations and they don't work, what are we supposed to do?
Keep trying is what I'd first like to say. Is, like I said in my presentation, something may not work once. It's about giving it time and trialing them consistently. Consistency is really important, but it's also about coming up with your own strategies as well once you've kind of seen the ones that DSA have offered. So maybe there's something else that you can think of that could help with maybe it's about distraction. So what else does the client living with dementia enjoy to do? How else can we engage them in something else? Thinking of other activities. It's really about having quite a large toolbox that you can always constantly pull from. But consistency is really the key here, and just try today and then try again tomorrow.
Thank you. Here's one that I might take myself, which is, what do we do when a GP does not document in the notes that consent has been sought? We hear frequently of difficulties working between GPs and providers, and we hear it from both sides. So it's not uncommon for us to be called by GPs saying, why is the Commission making us sign all these forms? And actually, we're not. There are no forms that GPs are required to sign, and we do see providers who have numerous forms that GPs are asked to sign. GPs need to be able to communicate the fact that they have not only sought but hopefully received consent for a medication they're prescribing, and they can really, there are a number of ways in which they can record that, and there are a number of ways in which they can communicate that to the provider. So if they call you up and say, I've got support from this, I've got consent for this medication for this person, and the person taking the call records that in their register in some way, that's a record. It doesn't mean that the GP has to have 10 forms put in front of them each time they come in. And don't forget, GPs don't have to sign forms for or particularly don't have to sign forms for non-chemical restrictive practices. That those forms, or that the record doesn't have to be a form, is your own. That usually that won't be even a GP involved in that decision, nor do they need to be. So where we hear that GPs are saying, well, I just prescribe what the nursing home tells me, and staff say, well, it's nothing to do with us because the GPs are the prescriber, it's a conversation. And we know that GPs don't just prescribe in a vacuum. They prescribe when they're given information that would lead them to believe that it's in their best interests to prescribe. So all of those things need to be documented. And you may overhear consent if the person's family member is there, and you can record it yourself. So where the GP documents it in their own notes, in your notes, however they communicate it with you, it needs to be a discussion that works for both of you, how that's communicated, but it doesn't have to be in any one particular spot. I've got one for you, Megan, here. Another question. Can you get someone external to complete behaviour support plans?
Yeah, so as a provider, you may choose to have an external person complete or be involved in the completion of behaviour support plans. But what is really important is that the person that is developing that behaviour support plan is an appropriate health professional to ensure that various elements, especially care and service provision, is within their scope, and that they can effectively inform the care and assessment for that individual consumer. Another important component is that a behaviour support plan needs to be well informed about the individual consumer's care. So that also you would expect that someone that has that day-to-day knowledge of the individual consumer is going to help develop a more meaningful and person-centred plan from that point of view.
Excellent. Jenny, I'm going to combine two good questions for you here. Do you need a diagnosis of dementia to refer to DSA? And can DSA help with home care?
Very good questions. So the first one I'll tackle with the diagnosis. So technically, a diagnosis would be the best way for us to have your involvement. But if there's a cognitive decline and you are seeking a diagnosis, because we understand that getting a formal diagnosis can be really tricky, especially for people living in regional and remote spaces. I know getting into a geriatrician like Melanie will be very tough, and so it's really hard to get those appointments. So you can still be involved if there's cognitive decline from the GP and you have seen that decline in that person. But best if we did have that diagnosis of dementia. But second of all, with the home care, 100%. So we can help on two sides in home care. So we can help support the person in the home with the loved one, supporting the person living with dementia, and the care provider coming into the home to provide the care for that person living with dementia. So really we can have a look at it at a two-way kind of support, where we're looking at that real practical ways to support the person living with dementia by the home care team, and then also give some tips and tricks to the person who's living at home day to day. You know, is that loved one, is that informal carer as well. So definitely if you're a home care provider and you are seeing some changes in behaviour of some of your clients, pop a referral through.
Thank you. This may be the last question, but Lauren, if the GP is asked to and does document that the medication is not a chemical restraint, then does the provider need to view the medication as chemical restraint?
Thank you so much for that question, and we do get that question a little bit. So the decision whether it's a chemical restraint or not is actually not the decision of the prescriber. That's actually a provider responsibility, because the provider is the people that need to follow the quality of care principles, whereas a prescriber is literally making a clinical assessment and prescribing that medication. So even if the GP writes this is not a chemical restraint, the provider has responsibilities and they need to understand whether it's a chemical restraint or not, and they need to make that decision. And again, that goes back to that psychotropic register and making the decision about the intent. It's not about what the GP writes or does not write in their notes.
Thank you. Look, that brings us very close to the end of today's webinar, but don't hang up. I just want to end it with the human face of chemical restraint. Really, really briefly, this is Brian Lynch, who appeared in person at the Royal Commission and told the Commission that he was in an aged care service given multiple medications, which in retrospect he doesn't think he needed. And when he was deprescribed, he got his life back. And he describes that time on chemical restraint as his lost years, which is very powerful. And this last one, which actually I have to say made me weep when I first saw it, was also presented at the Royal Commission. His family, he went in for respite. The first photo on the left is Terry on admission, and when his family came back from their holiday and visited him 6 weeks later, the one on the right is how they found him. And you can see, when I was talking before about you have to make sure the benefits outweigh the harms, that in Terry's case this was manifestly not so, and Terry never regained several aspects of his personal function when the medication was stopped at the insistence, rightly so, of his family. So look, thank you again to Jenny from DSA for helping us out here today, and also to Lauren and Megan for joining me. If you've got any other questions prompted by the webinar, please email them in, because as I said, we're going to put them together. But we really do want to remind you to please complete our survey, because we need your feedback on today's event. Particularly, we'd be interested in your interest in any future topics that the Commission could provide a webinar on. So do let us know, because it will help us. And just to remind you that there's a recording of this session which will be available on our website in the coming days, so you can either watch it again or share with your colleagues who you think missed it or might benefit. But thank you so much for so many of you being interested and for participating today. Goodbye, everyone.